Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are diving into insulin, a powerful, essential medication that every pharmacist needs to master. Whether you are reviewing a refill for type 2 diabetes, counseling on a newly diagnosed type 1 patient, helping a pregnant woman manage gestational diabetes, or educating someone picking up their first insulin pen, insulin is ours to own. Insulin saves lives, but it is also one of the most misunderstood and misused drugs in practice. And as pharmacists, we are the ones on the front line, preventing dosing errors, clarifying regimens, educating patients, and identifying patterns in glycemic control that others might miss. Before we get into it, make sure you subscribe, share this episode with your colleagues, and join our Telegram and WhatsApp communities. You will find the links in the description. And of course, feel free to connect with me on LinkedIn. Let's begin with a quick note to insulin's history. The discovery of insulin in 1921 by Frederick Banting and Charles Best was one of the biggest breakthroughs in medicine. Before that, a diagnosis of type 1 diabetes was essentially a death sentence. Once insulin became commercially available in 1923, diabetes transformed into a chronic condition that could be managed for decades. And today, it is our responsibility to make sure we manage it well. Pharmacologically, insulin facilitates glucose uptake in muscle and fat, suppresses hepatic glucose production, and helps convert glucose to glycogen. In non-diabetic individuals, insulin is secreted basally and bolus around meals. When we use exogenous insulin, our goal is to replicate that pattern as closely as possible with the right combination of basal and bolus formulations. So let's walk through the different types of insulin, because as pharmacists we are expected to know the onset, peak, and duration like the back of our hand. We will start with ultra rapid insulins like Fiaz, which start working within 2 to 5 minutes, peak in under an hour, and last about 3 to 4 hours. These are great for patients who eat unpredictably or forget to pre-dose. Next are rapid acting analogs, aspart, lispro, and glulysin, with onset around 15 minutes, peak at 1 to 2 hours, and duration of 3 to 5 hours. These are the standard choices for mealtime insulin in most outpatient basal bolus regimens. Regular insulin or short-acting insulin starts in 30 to 60 minutes, peaks at 2 to 4 hours, and lasts 6 to 8 hours. It is not ideal for meal coverage in outpatients because of the delayed onset and long tail, but it is still used for IV insulin infusions, hyperkalemia protocols, and DKA management in the hospital. Then we have intermediate acting insulin, which is MPH. It starts in 1 to 2 hours, peaks in 4 to 8 hours, and lasts about 12 to 18 hours. It is affordable but less predictable, and the peak can cause nocturnal hypoglycemia, especially if taken at night. Now to the basal insulins. Glargine, Detemer, and Degloric provide flat, steady insulin with minimal peaks. Glargines last about 24 hours. Detemer may need twice daily dosing in some, and Degloric lasts more than 42 hours and allows flexible dosing windows, which is great for patients with irregular routines. For type 1 diabetes, we calculate total daily insulin needs based on weight, usually 0.4 to 0.6 units per kilogram per day, split 50% basal, 50% bolus. The bolus is then divided across meals or adjusted based on carb counting. In type 2 diabetes, we often start basal insulin at 10 units once daily or 0.1 to 0.2 units per kilogram and titrate based on fasting glucose every 3 to 4 days. The mistake we see most, patients on 60 or 70 units of basal insulin, still with high A1C and no mealtime insulin. That's where pharmacists should step in and recommend adding bolus insulin instead of increasing basal doses further. Let's go through some basic real-world scenarios, the kind we all face in community and ambulatory care. We are working in community pharmacy. A 62-year-old man with type 2 diabetes picks up Glargine 10 units once daily for the first time. You confirm the timing and explain that it should be taken at the same time every day, ideally in the evening. You counsel on storage, keep it refrigerated until opened, then room temperature for up to 28 days, and you demonstrate how to use the pen. You also emphasize the need to rotate injection sites and to check fasting blood glucose daily to help with titration. Another day, a 45-year-old woman comes in with a prescription for MPH 20 units at bedtime, which she has been taking for years. She complains of feeling shaky around 3 a.m. You suggest she discusses with her doctor whether the dose or timing should be adjusted, or whether she should have a bedtime snack, or even consider switching to a basal insulin with less peak effect. Your counseling may prevent a hypoglycemic episode that was about to happen. A patient comes in with regular insulin and asks if they can inject it right before meals like their old aspirin. You step in immediately and clarify. Regular insulin needs to be taken 30 minutes before eating, not right at the meal, or they risk post-meal hyperglycemia and late hypoglycemia. This is one of the most common mix-ups when switching between insulins. Another patient in her first trimester of pregnancy is starting MBH and regular insulin for gestational diabetes. You confirm the timing and remind her to check glucose levels before meals and 1 hour after. You also explain that insulin is safe in pregnancy, and this combination has decades of use behind it. She leaves confident and empowered because of your guidance. A patient on a basal bolus regimen says she's running high before dinner. She already takes glargine and rapid-acting insulin before meals, but admits she snacks around 4 p.m. without insulin. You identify the gap and recommend adding a small correction bolus for the snack based on her carb ratio. Problem solved by the pharmacist. Let's go to some counseling essentials. Insulin should be stored refrigerated until opened, then at room temperature for 28 days. Patients should know that each injection site, abdomen, thigh, buttock, arm, should be rotated to avoid lipohypertrophy. Remind them about sick day rules, how to manage a missed dose, and always ask, do you carry fast-acting glucose with you? If they are on mealtime insulin, make sure they know how to match insulin to carbs, even at a basic level. Some patients do not even know what counts as a carb. That's where your education comes in. Let's wrap it up with some rapid-fire Q&A. What's the insulin of choice for IV use in the hospital? Regular insulin. What is the longest-acting insulin available? Deglodic, Tresiba, lasting over 42 hours. How long should open insulin be stored at room temperature? 28 days, though it may vary slightly by brand. Which insulin must be taken 30 minutes before meals? Regular insulin. Which basal insulin allows flexible dosing windows? Deglodic, Tresiba. What is a major risk with repeated injections at the same site? Lipohypertrophy leading to poor absorption. What is a basic starting basal dose for a type 2 patient? 10 units once daily or 0.1 to 0.2 units kilogram per day. That wraps up today's insulin session. Simplified but powerful. Whether you are dispensing, counseling, adjusting, or educating, pharmacists play the most critical role in making insulin safer and more effective for patients. If you found this episode helpful, do not forget to subscribe, share it with your colleagues, and join our Telegram and WhatsApp groups. And if you have ever caught a basic insulin error or turned a confused patient into a confident one, I want to hear it. Let's connect on LinkedIn. Until next time, this is Momin Wali reminding you, catch mistakes before they catch you. See you then.